Thank you. Good evening. Can you see my screen?
Yes, we see it.
Yes? Full screen?
Yep.
Okay. So many things have already been said by Professor Leleu. So I would like to speak about supportive care in patients with multiple myeloma treated with CAR-T cells. You know that we have now plenty of options, in fact, that were approved since 2015. 27 new options are available and approved by EMA and by FDA. But for very advanced patients, you can see that we have now two CAR-Ts that are approved, ide-cel and cilta-cel, and these two CAR-Ts are targeting the same antigen, BCMA, B-cell maturation antigen. And in fact, we are using these CARs for very advanced patients, but you know that the majority of our patients are now becoming triple class refractory very quickly, in fact, indeed, after 2 or 3 lines of treatment. For example, frontline with stem cell transplantation and lenalidomide maintenance, the patient will progress on lenalidomide and will become refractory to len. At the time of this relapse, we are going to use KD plus a CD38 antibody, KD-DARA, KD-zatuximab, until progression. So the patient, after 2 lines of treatment, is now progressing on lenalidomide, carfilzomib, and a CD38 antibody. This patient is now triple-class refractory. And what is the outcome, in fact, of a triple-class refractory patient without immunotherapy when we cannot use CAR-Ts? In fact, you can know this outcome looking at the locomotion study that was a real-life prospective trial in patients that were, the majority of them, triple-class refractory. And 248 patients were treated, were assessed, and the response rate is 30% only, and we have used more than 90 different regimens to try to control the disease, indicating that there is really no standard of care for very advanced patients. And the median PFS was very short, less than 5 months, and the overall survival is 1 year. So definitely, we need to improve on those results, and this is the algorithm, in fact, that we can use when patients are refractory to IMiD, to PIs, and to CD38 antibody. We can use now anti-BCMA strategy, either bispecific antibodies or BCMA CAR-Ts. And we have 2 CAR-Ts. We have the KAMA study with ide-cel, and Xavier Leleu showed you the results with 82% of response, incredible response rate, and a progression-free survival of 1 year, and the median overall survival with a target dose of 2 years. And recently, cilta-cel was approved. That's another CAR-T, in fact, with 2 single-domain antibodies targeting 2 different epitopes of BCMA, and this is conferring to cilta-cel a higher avidity and a higher affinity to the target. And this CAR-T was developed in the CARTITUDE-1 study, and you can see that patients were very advanced, triple-class refractory, but the median dose of CARVYKTI, of cilta-cel, is 0.7 million per kg. And in fact, that's 10 times less as compared with ide-cel. So the construct is different. Cilta-cel is not ide-cel at all, in fact. And the responses are very quick. The overall response rate was incredible, 98%. And we have heard about the update analysis of PFS and OS, and the PFS is really outstanding, almost 3 years in median for very advanced patients. And the overall survival is also incredible, in fact, 63% estimated at 3 years for overall survival. But we need to control, we need to be on the safe side as well. because those CAR-Ts are very, very active, but the two of them are associated with cytokine release syndrome. And this cytokine release syndrome is occurring, in fact, within the first week after the infusion of the CARs, when the CAR-Ts are expanding in the peripheral blood. So that's a very early complication of CAR-T cell therapy. And we have to suspect if there is either fever, hypotension, hypoxia, or an significant organ toxicity. So the patient needs to be in the hospital, and we have to monitor carefully during this first week following the infusion of the CAR-Ts. Every 4 hours, we have to control the vital signs of the patient. And we are using for cytokine release syndrome this scale, in fact, to assess the grading of the CRS from grade 1 to grade 4. And you see, that's a very simple way of assessing CRS. Grade 1, that's fever alone above 38 degrees, without hypotension, without hypoxia. As soon as you need some vasopressors, as soon as you need oxygen, there is a grade 2, in fact. And you see that for grade 1 or grade 2, that's a quite simple assessment, and also we can easily control the CRS. Grade 3, the patient needs to go in the intensive care unit. And what are the rates of CRS? In fact, with those two CAR-Ts, in the KAMA study, in the CARTITUDE study, you see that more than 80% of the patients, 80%, did experience CRS. But the vast majority of them were only grade 1 or 2, very few grade 3, in fact. And those CRS are very predictable. With ide-cel, the median onset is 1 day, in fact. And with cilta-cel, we are infusing less cells, 10 times less. And the expansion of the CAR-Ts are occurring later, in fact, within the blood of the patient. And you see that the median onset is 7 days. So with ide-cel, very early, 1 day. With cilta-cel, 7 days. And the median duration is roughly 4 to 5 days. And in the real-life experience as well, published with ide-cel recently by our colleagues from the US, you see that the CRS rate is identical. In fact, that's 82%. So in the real-life setting, we are confirming the data from the pivotal study for the approval of those two CAR-Ts. And we can use some guidelines, in fact, and one of them were recently published, the European Myeloma Network guidelines in the Lancet Oncology a few weeks ago, how to manage adverse events during treatment with CAR-Ts. And for CRS management, that's very easy, in fact. For grade 1, you are just observing your patient, and you don't have to propose anything. As soon as you're reaching grade 2, you need to use tocilizumab. Tocilizumab 8 milligrams per kg IV, 1 dose, and you are monitoring your patient. And in the majority of the cases, you can control easily the CRS with toci alone. If you are not controlling immediately the CRS, you can use another dose of toci, a second dose of 8 milligrams per kg IV as well. And then if the patient is not improving quickly, you can consider early dex with a dose of 10 milligrams of dexamethasone. If grade 3 or no control of a grade 2, intensive care unit immediately. But some of us are treating patients very early, as soon as we have a grade 1, in fact, in order to reduce the risk of grade 2 or 3, and toci alone is easily controlling a grade 1 CRS. So this is the table from the guidelines from Dr. Ludwig, and you see that for grade 1 supportive care, and we can use antipyretics in case of fever, and grade 2 administered systematically. So the guidelines are quite very simple, in fact. The second adverse event is this specific neurotoxicity, immune effector cell associated neurotoxicity syndrome, what we are calling ICANS. And in fact, this is related to the diffusion of the cytokines into the brain, and that's also very easy to grade ICANS. You have to suspect in case of somnolence, in case of confusion or disorientation, in case of seizures, for sure, or diminished attention of your patient. And you need to monitor every 4 hours, obviously. So we have to use this score, that is the ICE score. That's a score of 10 points, and that's very easy. Every day, you have to speak with your patient and to reproduce this score on a daily basis following the infusion of the CAR-Ts. The score of 10 is a normal score. And you see that the score of 4 points for orientation, you are asking to your patient, where are you? What is the date today? And the patient has 4 points if the answers are good enough. Then naming 3 points, and you are showing to your patient 1 pen, the clock, etc. And he has to tell you, this is a pen, this is a clock. So very easy and very quick as well. And a score of 1 to follow some simple commands. And you are looking as well the ability to write a standard sentence that you are proposing daily to your patient. And then attention, 1 point, with the ability to count backwards from 100 to 10. So if you have a score of 10, there is no impairment. A score of 7 to 9, this is a grade 1 ICANS. A score of 3 to 6, a grade 2 ICANS, and score of 0 to grade 3 ICANS and intensive care unit as well. So this is the I score, and you have other parameters, obviously, that you are following to grade your ICANS. And this is, again, the scale from Dr. Lee, published 4 years ago. So what about the ICANS rate, in fact, with these 2 CAR-Ts, ide-cel and cilta-cel? You see that 20% of the patients did experience some neurotoxicity, the majority of them with grade 1 or 2, very few grade 3, less than 5%. And also, the onset is quite reproducible, predictable, 2 days for ide-cel and 8 days for cilta-cel. So very often you have this sequence of CRS first and ICANS immediately following your CRS. And in the real life data set from the US group, we have exactly the same numbers of ICANS, 18% for those patients treated with ide-cel outside clinical trials. So how to manage ICANS? That's very simple as well. Grade 1, early dexamethasone. Grade 2, dexamethasone as well, 10 milligrams every 12 hours. And grade 3, you need to speak with your colleagues from the intensive care unit. And this is also clearly mentioned in the guidelines published by Heinz Ludwig very recently. Cytopenias is an issue, not a big one, but is an issue related to the tumor burden, the involvement of the tumor cells within the bone marrow, the infiltration of the plasma cells, but also to the lymphodepletion that we are using based on fludarabine and cyclophosphamide mostly, that can lead to long period of neutropenia. And the time until blood recovery into the KARMA study for a normal blood count in median was 2 months. So that may happen early and last 6 to 8 weeks, in fact. And with cilta-cel, the majority of the patients are recovering after 1 month, in fact. For cytopenia, we have obviously to use platelet transfusion in case of thrombocytopenia, anemia, that's very simple as well. And for neutropenia, GCSF is commonly used. And those rates of neutropenia, anemia, thrombocytopenia are really identical, in fact, when looking at the real-life data with ide-cel in the US. There is a special neurotoxicity that can occur later and is not ICANS. ICANS, that's very early. And that was reported mostly with cilta-cel. In something like 10% of the patients, we can have, after 1 month in median, a new neurotoxicity. And you can observe this adverse events with micrographia, with difficulty to walk for your patients, a sort of Parkinsonism syndrome, in fact, with bradykinesia as well. So you have to monitor carefully your patient. The patient after 1 month can be in the outpatient setting for sure, but you have to tell your patient in case of new symptoms, he has to come back immediately to the hospital. And this is related to the fixation of the CAR T cells in the caudate nucleus. And this is one case of very severe late toxicity leading to death, in fact, for this patient. What about infections? We need to use, in fact, prophylaxis systematically, an antiviral one with valacyclovir. We need also to use systematically cotrimoxazole. We are not using systematically antibacterial or antifungal. That's something that we are not doing in France, for example, but some centers can use levofloxacin or fluconazole. That's not my practice. My practice is really valacyclovir, cotrimoxazole, and a systematic IVIG replacement in case of severe hypogammaglobulinemia with an IgG level less than 4 grams per liter, in fact. But this duration of replacement is not very long. With CAR T, that's different from bispecific antibodies. You need probably only 2 to 3 months of IgIV replacement. So this is what we are doing. Consider prophylaxis during treatment, cotrimoxazole, valacyclovir, and IVIG, as I told you. And in case of fever, you have to tell your patient, please come back to the hospital if it's 1 month or 2 months after the infusion. And you need, of course, to monitor viral infection, look at CMV reactivation, EBV reactivation. You have to monitor fungal infections if the fever is above 38.5 and is lasting a long period of time. And this is also the picture from this guideline paper with cotrimoxazole, IVIG, and obviously valacyclovir as well. And I would like to thank you for your very kind attention today.